This program is a presentation of UCTV for educational and non-commercial use only.
Good evening. I'm going to try to start on time. Our numbers are dwindling a little bit, but I'm glad that you all braved the dampness to join us for tonight's lecture. I'm Margaret Chesney, the director of the UCSF Osher Center, and we're talking about life in balance, as you know. We are talking about all kinds of balance, work-life balance, and we've covered individual health and vitality. We've talked a lot about what people eat. We've talked about stress. And as you remember, Ellen Hughes, if you were here for the first lecture, she talked about people who are more mature, as we might say. And then I promised that we would also talk about health across the whole lifespan, because many of us have opportunities to influence littler people in our lives, including children, grandchildren, children of friends. I mean, we are a village. And so there's opportunities, even if you don't have children at home, to want to know more. What is it that we can do? So we're going to be talking about family health tonight. And it's really an incredible pleasure for me to introduce tonight's speaker, David Becker. He is Associate Clinical Professor in the Department of Pediatrics at UCSF here, and where he's been on the faculty since 2001. He received his medical training and received a master's in public health, as you see here, showing his reflection of concern about people not only as individuals, but sort of communities. He received all of that training and did his residency in pediatrics at the University of North Carolina at Chapel Hill, which, by the way, is one of the best public health schools in the nation. So he's really had some excellent training. He then went on and participated in that fellowship that Andrew Weil has at the University of Arizona to receive training in integrative medicine. He has also had additional focus training on pain management and on mind-body medicine, how our bodies affect our minds and how our minds can be used to affect our body. And that was something that you'll remember Alyssa Essel spoke about. What's really remarkable, too, about him is that he, like Daphne, have traveled the world to bring medicine to the world. And he spent 2 years in global humanitarian work in Sri Lanka with Doctors Without Borders. What's particularly important to me about Dr. Becker is that he has also been very connected with the Osher Center. If you receive our newsletter, you'll notice that he has been having a column for the last year or so talking about vitamin D and everything you might want to know about children. And I think we have all of your emails, so I'll make sure that you can get on the newsletter list for the future. He has also been doing an integrative pain clinic here at UCSF in the Department of Pediatrics. And I was so impressed when I was interviewing for the position of director. And I met David, and I thought, we should be doing integrative pain clinic for children right at the Osher Center. And so I'm just thrilled to say that I began in January, and I think it was in August, we brought Dr. Becker. He's still in pediatrics, working with children there, but we brought him to the Osher Center to provide integrative pain management and pain clinic, as well as some consultation around pain issues in young people. So he's practicing at the Osher Center now. Because I have to tell you, if you have, within the Osher Center, we do research, we train physicians, we love to work with the public, but what's really important also is to have a clinic. And I walked in, and the waiting area, and if any of you are interested in integrative medicine in any capacity, acupuncture, seeing a physician to talk about your diet, there's this, we have a clinic, but it was too clean. It was too tidy. It was too organized. Where were the toys? Where are the little people? And I found out that there'd been sort of a policy that we didn't see children except under special circumstances. And I thought, oh, this isn't okay. So we fixed that. And I'm thrilled to have brought integrative medicine for young people to the Osher Center. And there is no better person than David Becker to be the person to lead that, to really be the first person to bring that care to our center. And he's going to bring that wisdom to you tonight. So it's with pleasure I introduce Dr. David Becker. It's also very tall.
Thanks very much, Margaret. That was very kind of you. And I'm very happy to be spending a significant amount of my time at the Osher Center now. It is by far the most welcoming group of people to be practicing medicine and to be investigating and looking into education and the development of new ideas and integrative care. It's a great place to be. Let me get my slides up here. So, it was last night as I was kind of going through these slides again, and it was also at about 7 o'clock, and I realized 7 o'clock, and you all are going to come here, and we're going to talk about healthy families, and this is probably prime family time. So it's like, okay, the timing's a little bit funny, but I'm really glad you all came out, and I'm glad you all came out and braved the little bit of the rain, and that you're here. And so in this, we've got plenty of time this evening to go through these slides and also to address questions and talk about things that come up. So if you do have questions and things that come up, write them down, and I'm happy to talk about them further at the end. But in general, we're going to talk a little bit about the scope of health of kids, and I'm going to focus primarily on children, which is mostly what I work with, small infants and teenagers. And we're going to talk a little bit about the scope of the issues that kids face and that our families face currently. A little bit about what an integrative model means when it comes to thinking about child wellness and child healing. And then on a little bit more practical level, we're going to talk about several areas of integrative concepts of care, nutrition, natural health products, mind-body skills, some issues about the environment, and just to touch on a little bit of the science and a little bit about the art of practice. We're going to cover both of those areas a bit. So why focus on children? Why an emphasis on this? Why bring up when we're talking about healthy lifestyles? Why talk about kids? And I really like this quote from UNICEF, and I think it kind of brings us home to this. I'm just going to read it. The true measure of a nation's standing is how well it attends to its children. Their health and safety, their material security, their education and socialization, and their sense of being loved, valued, and included in the families and societies into which they're born. This is a slide that was I borrowed. There's a group of us who do work in integrative concepts, and we kind of share a lot of material sometimes. This is from my friend, Dr. Larry Rosen. One of his favorite quotes I wanted to bring in too, from the 19th century. Life and health of every infant are both economically and morally of paramount importance to our society. So how are we doing in our society? If you look at, this is again from the same UNICEF study, if you look at questions and you ask young kids, 13, 11, and 15 years of age, what percentage of them will rate their health as either poor or only fair, and where are we? The key part is where we are in this scale. Such a large proportion relative to these other developed countries, in our country, and these kids rate themselves as poor health. So, we face a lot of serious challenges if we think about the broad influences of health for our kids. And I'm using the word ecological framework here on purpose. We're thinking beyond just environment. We think about all the influences that affect kids' health. Nutritional, the changes in our nutrition system, the way foods are manufactured and processed, how that may be affecting our health. Environmental, the tens of thousands of chemicals that are introduced into our environment without safety testing. Educational, shifting in our education systems into how well we're taking care of our kids and enabling them to face the challenges of the future. Familial, cultural, and relational, all aspects of our society and how we relate to each other and how we may or may not becoming a little bit more disparate and less of more cohesive units where we can support each other. So in another way of thinking about the scope of the problem, a couple of slides talk about chronic conditions in kids. This is one of the hottest topics when we think about pediatric care, the rise of chronic conditions in the pediatric population. 1 in 6 of our youth between 6 and 19 years of age are overweight. This is a 45% increase in the last 10 years alone. Asthma. Between 1980 and 2008, the percentage of children with asthma has increased from 3.6% to 9.4%, and it's become the most prevalent chronic disease affecting American kids. About 1/3 of American children suffer from some form of allergies. And our ambulatory care visits for food allergies have tripled just in the last 10 to 15 years. Nearly 10% of kids have the predominant antibody against peanuts now. Diabetes in kids affects about 1 in every 400 to 500 kids. And it used to be, are you all familiar with the difference between type 2 diabetes and type 1? The adult onset, usually called adult onset, which happens later in life. Well, it used to be that about 5% of kids, when they were diagnosed with diabetes, had the adult onset or type 2 diabetes. Now nearly 50%, or half of kids, have the adult onset version of diabetes when they're diagnosed. So not 50% of kids are diagnosed with diabetes. Of kids who are diagnosed with diabetes, 50% of them now are diagnosed with type 2 diabetes instead of type 1. Cancer, interestingly enough, is one of our success stories in pediatric care. Acute leukemia now is curable in the vast majority of cases in kids. But if you look at overall rates of cancer in kids, between 1975 and 2002, the age-adjusted annual incidence of cancer in kids has actually increased. If we think about mental health, 20% of our children are estimated to have mental health disorders with at least mild functional impairment. And about 5 to 9% of kids between 9 and 17 have a severe emotional disturbance. This is from the National Institute of Mental Health. Neurodevelopmental disorders, which include attention deficit disorder and autism. 1 in 6 children is diagnosed with some form of a neurodevelopmental disorder now. 1 in 10 have ever been diagnosed with attention deficit or attention deficit hyperactivity disorder, and 1 in 20 or 5% carry a current diagnosis and are on medication. Now, autism spectrum disorder, which we're not going to get to in detail in this talk, the rates, I think, have clearly increased. There's an ongoing debate in the scientific literature on whether or not that is a real increase in the baseline rate of autism or if it has to do with classification of the disease. Regardless, the overall rate of autism now in newborns is 1 in 110. If you happen to be male and born in New Jersey, the rate of autism in boys in New Jersey now is somewhere between 1 in 60 and 1 in 90. So what's been their standard response? And this is a bit of a simplification. But this is frequently how I might feel amongst my conventional colleagues about what our usual response is. I don't know how much of this you can read, but take your pick, whichever month your pill of the month. This has generally been the pharmaceutical response, if we think about it narrowly from that standpoint. I have to wonder how beneficial is that for our health? Or in the pediatric community, it often feels like this. And I want to read you just briefly, this is actually an article from the Reuters news service that was published in May, and it had to do with a pharmaceutical industry analyst report. And it says, Children were the leading growth demographic for the pharmaceutical industry in 2009, with the increase of prescription drug use among youngsters nearly 4 times higher than the overall population, according to the report. More than 1 in 4 insured children in the U.S. and nearly 30% of adolescents aged 10 to 19 took at least one prescription medicine to treat a chronic condition in 2009. This is according to analysis of pediatric medication use conducted on part of Medco, which is the industry analyst. Medco is forecasting overall pharmaceutical spending to rise up to 18% through 2012, driven by diabetes, cancer, and rheumatology treatments. Spending is expected to rise 3% to 5% this year and 4 to 6% the next 2 years. Overall increases will be somewhat held down by the some $46 billion in branded drug sales that will succumb to competition from cheap generic versions in the end of 2012. If a major influence of our healthcare system development is based upon a purely profit motive and model of developing pharmaceutical drugs, we're missing a huge piece of care for our kids. Now, I want to be really clear. I am not against pharmaceutical drugs. I use them every day. I prescribe them regularly. They are fantastic supply of a critical part of our healthcare system. But if it's really, so much of our system is driven by this development, both economically and from a research standpoint, we're limiting our range of the ways that we can influence health in kids. What if we were to take a different approach? What if we were to think outside the box? Well, if you're a cat, it's not a good idea. But for us, maybe it's worth a little thinking. So just an example that some of this is happening when we think about shifting from a disease care model, one where we're identifying and trying to address problems based on a disease name, and we think about health care or wellness or improving health, regardless of what some underlying condition may be, there is some movement in this direction. This is from a news article in the pediatric literature focusing on what's right with the child. This slide, again, is from Dr. Rosen, but this is a summary of some of the recommendations from a colleague of ours, Dr. Kathy Kemper, who is a leader in pediatric integrative medicine, on fundamentals for creating a healthy habitat, focusing on communication and relationships, nutrition, which we're going to talk about a bit, fitness, stress management. We're going to talk a little bit about that too. This is a fantastic book and by far the best available when it comes to pediatric mental health and an integrative approach to care for them. So some principles of how we think about what does it mean, what does integrative practice in pediatrics mean? And this, to me, is, these are key aspects of help that guide me think about how I'm interacting with my families and kids every day. You take the child in the context from which they come, their family, their social circumstances, their school, their peers, their genetic background or epigenetics, although we don't have time to get into that too much today. A focus on wellness and prevention and healing with cure in parentheses on purpose. It's absolutely important and critical, but if we focus only on cure, we lose the rest of supporting kids in the process of dealing with what they may be dealing with in chronic disease. It's relationship-based, both between physicians and families and among healthcare providers. Individualized therapies, respectful multidisciplinary collaboration, empowerment. This is really, really important for kids. And it's something that I think that is traditionally ignored in much of our interactions as we tend to assume a role of prescribing and saying what's going to happen. But empowering kids to heal in the context of their environment. We're going to talk a little bit about how you can do that through language. And these, to me, kind of sum up as simply just good medicine practices. So just briefly, this idea fits into a broader idea of ecologically sustainable medicine, a practice which is, if we think broadly and think more ideally, safe and harmless, one which is clean and non-toxic to our environment, cost-effective, non-polluting, adaptable and flexible, renewable, and protective of the quality of life on Earth and the environment and the Earth's natural resources. I like to think big, at least. So we're going to shift a bit and move on to thinking a little bit about some of the science and some of the art of practice in several areas. And I know that you guys have already heard from Dr. Miller quite a bit about nutrition and her experiences throughout the world, and we're going to focus a little bit more on kids here. So believe it or not, a great source of health news recently has been the New York Times. Their health section is quite good, and this, to kick off this discussion of nutrition, comes from an article from September. This is the title of the article, "Told to Eat Its Vegetables, America Orders Fries." So we know that from our current recommendations are to eat 5 to 7 servings of combined fruits and vegetables a day. It turns out that less than a third of adults eat 2 fruit servings a day, and about a quarter will eat 3 servings of vegetables a day. And what was most interesting to me about this article were the quotes from a guy who's an industry analyst who comes from the industry, the food industry. And he said, yeah, before we want health, we want taste, we want convenience, and we want low cost. And he's right. We can't fight that, I think. And this next part, I think, is one of the key parts to me as a clinician and as somebody involved in working with families and kids in the environment. He says, there's nothing you can say that will get people to eat more veggies, which to me is a clue and has something to do with what we do and how we help families do rather than try and say. We're going to come back to that in a minute when we talk about nutrition again in a minute. Omega-3 fatty acids we're going to touch on a little bit later when we touch on supplements. A brief comment about introducing solid foods. So there's a lot of traditional practice, and there's a lot of conventional wisdom, and there's a lot of medical ideas that have generally been start at 6 months with your yellow and orange vegetables, move on to your green vegetables, your fruits, and then some meats, and then some grains. It turns out that in a review of this literature just a couple of years ago, we actually really don't know. And the best knowledge that we could come up with is you don't want to introduce solid foods until at least 6 months because you want to give the gut some time to mature, to protect the barrier between the inside of the intestinal lining and the immune cells of the gut. And if you wait till 6 months, what you introduce after that probably doesn't matter. Could be ground beef. It probably doesn't matter. And I say probably because we don't really know for certain. So there's a wide range of traditions about what foods you introduce early, and it probably doesn't make that much difference. Another theme about nutrition in kids has to do with food additives and colorings in diets. And some of you all may have heard of the Feingold diets that were advocated in the 70s and 80s for kids with attention problems. You know, this is really based on this original study looking at reduction of hyperactivity in kids with removal of artificial food flavors. But the literature for the following 10 to 20 years wasn't as clear. You know, the data were mixed about whether or not removing these components from the diet really made much difference. And the general idea was that it probably didn't. But in the last couple of years, there have been a few more really well-designed studies that have looked at kids in randomized trials where they've removed a number of food colorings and removed several preservatives like benzoate, sodium benzoate in particular. And in preschool kids in this top study found a significant improvement in their behavior when these were removed from the diet. And then in a study in Lancet with kids both preschool and a little bit older also found improved behavior in these kids when these components were removed from the diet. So there is some evidence that suggests probably in a subpopulation of kids with attention-related problems that some of the components, some of the artificial components and the manufactured components in our diet can influence their behavior. So how do we respond, or how do we think the data on nutrition in kids, there's a whole lot more to get into, but because we're trying to cover a broad scope in the talk, we're going to limit it to just a few things and then talk a little bit about practical aspects of how do I talk with families about diet and improving their diet in general. And what it boils down to me is thinking about what we call whole foods diet. Have you all heard that term before, whole foods diet? So basically, it's using whole grains instead of any processed grains. Fresh fruits and vegetables, lots of colors, legumes, nuts and seeds, fiber, water is your source of liquids. Fish and meats, as Dr. Miller was talking about, if they are free-range meats, your components of your omega-3 versus your omega-6 fatty acids are going to be much better balanced, and avoiding processed foods as much as possible. Some of the specifics are reducing saturated fats from red meat and poultry, reducing the amount of omega-6 fatty acids by reducing margarine and taking out many of the vegetable oils or hydrogenated oils. Increasing omega-3 fatty acids with cold water fish. Flaxseed or flax oil can be helpful for families that are vegan or vegetarian. However, the efficiency of our body's conversion of those to the omega-3s is not as good as taking it from fish sources, and the oil can go bad. Some nuts are great sources, green leafy vegetables, and again, the free-range sources of meats. Many of you may be familiar with a Mediterranean diet. It's another option of a way that has been shown in some studies with kids to be associated with reduced rates of asthma, for example. So what about, you can hear all the advice, you can hear all the ideas. This is us as providers saying what to do. How do you do it? We can say, it's actually pretty simple. This is food, pretty easy. Your farmer's market supplies of fruits, vegetables, grains, a variety of spices, free-range meats. It all looks nice too. This is food. This is not food. Food. Just in case you didn't get it. Not food. It's really pretty basic. Now, I'm not saying that this is all evil. At some stage in my life, I have had something like everything on this slide, and I still do. I actually like the spicy gummies. I mean, they taste good, right? And yes, I've been, the spicy chicken from Popeyes. Ooh. But it's a rarity, and the way I think about it is that it's not nourishing for me. It may substitute for much of the essential components of my diet and what I need to get by, but it's not nourishing my body. It is not food. It's a substitute. And then Michael Pollan's famous quote, which I like a lot, it kind of boils it down. Eat food, not too much, mostly plant. Oh yeah, okay, so the next step in this, if we're thinking about working with families and kids, all these ideas are great, but how do you go from this, and this, and this, which is my favorite one, because he's saying, don't even put it on my plate, because I'm not even gonna look at it. How do you go from this to this, and this, and this, without bribing them with whatever your Butterfinger or, $1 or whatever decides. How do you do those? How do you move from there to there? Well, you can also do this, and this, and this, and this. Getting kids involved in the process of food from the very beginning, whether it's in gardens, in organized programs where they learn about what it's like to plant seeds, to see what happens when plants grow, to harvest them themselves. Kids will eat radishes straight out of the ground if they're involved in the garden. But if you put it in their plate some other time, give me a break. Get them to prepare foods in the kitchen and let them make a mess into the process of what they're doing. And this process of becoming part of what they're doing will get them more invested in what they are. And finally, I like asking audiences this question. In the last month or several months, how many of you have had more than, say, this is a tough time, we just had Thanksgiving, but how many of you have had 3 generations at a table consistently in the past 4? That's great. This is not an accusation. I mean, it doesn't happen with me either. It's kind of the state of where we are with our lives now. We are more separated. We do not have multiple generations of people at the table consistently to help each other, to model for each other, to guide the younger generation as much. All right, dairy. I love milk. I still drink a lot of milk. But why cow milk? Why is it so predominant and so prevalent and so considered such an essential staple? As I work with it, when the families come in, when do I change to cow milk? When do I, as infants, when do I change? When do I start with it? Well, why do we do it? Well, it's a great source of protein. It is a great source of healthy fats. It's an excellent source of calcium. Tastes good. There's added vitamin D in it to help support as well. And this is the big one. The U.S. Department of Agriculture says so. I mean, this has been the case for decades, and promoting the products that we make as a society in our farms. But there is nothing in our own nutrition or our bodies that says you must have dairy products. You can get each of these components in our diets in other ways. And I say that not to say that you shouldn't drink cow milk. I love it, it's fine too, but just to say that it's not necessary for kids. A couple topics about raw versus pasteurized, and there are many other varieties, goat milks and other nut milks, but we don't have time to get into the details of those at this time. We can maybe talk about them afterwards. Okay, natural health products. Just quickly, natural health products are basically botanicals, probiotics, vitamins, minerals, supplements, things that you get over the counter for the most part. We're going to talk a little bit about upper respiratory tract infections in kids, vitamin D, omega-3 fatty acids, probiotics, and some general principles when we think about herbs and supplements. Colds. One of the most common reasons kids end up coming to the clinic, and one of the ways that families are flummoxed with what to do when kids just have constant runny nose and stuffy noses. Well, the first thing to keep in mind is that kids, normal, healthy kids, get between 6 and 8 colds a year, pretty much no matter what, on average. So the idea of having like this year after year of not having any colds is probably an unrealistic one, and it's not necessarily a bad thing for us to get the infections. It's an aspect of challenging our immune system and getting accustomed to our environment. Now that said, we'd still like to turn to what we can for some relief when we get colds. It's become clear that the over-the-counter products, the decongestants, the antihistamines, the antitussives, the ones that are pharmacologically based, do not have evidence to support their use in kids. And in fact, many of them have been removed from the marketplace, mostly because of complications of misuse or combining products where you have side effects with kids. So that leaves a lot of families with questions. Well, what else can I do? So there are a range of things that have varying degrees of evidence for their efficacy, but we have a fair amount of knowledge about safety. And echinacea is a great example. In echinacea, if you're not an herbalist or a botanist or you're not familiar with it, it's kind of hard to go to the store and figure out, well, which product would I use? There are 3 different plant varieties. You can use the flower part, the stem part, the leaf part, the root part. What do you do? This has complicated the research too. So probably the most definitive study in kids was the JAMA study in 2003, I believe. I may get these two mixed up. Which one was JAMA, which one was New England Journal, but Dr. Chesney will remind me. And it was actually pretty clear in a reasonably done study in kids that the treatment of colds with Echinacea purpura was not that effective. To me, does that mean you shouldn't use it? Not necessarily. I still think if your personal experience is one that really helps, you can still use it. But probably the most frequently cited and considered definitive study was a study that was designed beautifully well, that randomized adults for prevention of colds with angustifolia, which is probably the most commonly used, or one of the most traditionally commonly used echinacea plant. They looked at prevention, and they looked at a treatment model, and they isolated people in rooms, and they squirted the rhinovirus in their nose, and they studied everything aspect about them, and it was beautifully controlled. And the results were that it didn't work. It didn't help prevent, it didn't help treat colds. Problem was, nobody who designed the study went to the herbalists and botanists and said, oh, by the way, what dose should we use? And they used a dose that was far less than what the traditional use was of angustifolia. So the press gets hold of this, and the press says, oh, look, echinacea doesn't work. But in truth, we don't really know the answer. Does it work? I don't really know. Is it safe to use? Yes. You can use it in kids, especially who are school age and older. If you do want to use it, especially in younger kids, you want to use a glycerin preparation and not an alcohol extract. And you would start it right at the beginning of the cold, and you would do it every 2 hours or so, right from the beginning, if you wanted to. It's a safe thing to do. Vitamin C. We have modest evidence that it can have some preventive and treatment effects in kids at moderate doses. We're looking at 250 to 500 milligrams a day in kids that can be used during cold season or at the onset of symptoms. Saline irrigation. This has become more popular now, although to teach a 4-year-old or a 3-year-old or 6-year-old to use a neti pot or some version of a saline irrigation doesn't always work. Although I do have families that have success with it and kids get used to it. And some of them actually kind of like the idea of pouring stuff in one end and their boogers coming out the other. So if you can have fun with it, they'll get into it. Zinc. Zinc has been a pretty popular remedy over a couple of years as well. And we actually have some fair evidence that says if you use a zinc lozenge with about 15 milligrams of zinc and you dissolve it in your mouth, you don't chew it, and you do it about every 2 hours, and you do it at the onset of a cold, you might shorten the illness by maybe a day. I would really advise you not to use the nasal spray, however. I don't know if you heard about Zicam and the problems with the nasal spray as it affecting smell. A number of people have reported that after using the product, they completely lost their sense of smell. This is debated by the company, but I think it's become pretty clear that it is a risk. Anybody know what oscillococcinum is? It's a homeopathic remedy. It's probably the most popular homeopathic remedy this time of year, and it is used predominantly for influenza treatment. And homeopathic remedies in kids are extraordinarily popular. They may well be quite effective, but our data, or at least the high quality data, are lacking to support their use in kids. That said, they're very, very safe. The caveat to that is you just need to know that you actually have a truly homeopathic product and not one that's only marketed as homeopathic. These homeopathic remedies are substances, and this one in particular, when you buy oscillococcinum, it's made from originally duck heart and duck liver. But when you actually take the tablet, there's none of that left in the tablet. It's been diluted over and over and over so much that the molecules of the product are gone. And again, if we have time at the end, we can talk a little bit about the theory of homeopathy and how you think about using it in kids if you like. That said, scientifically, we don't have an explanation for why it might work or not. But one of our most conservative review publications, the Cochrane Review, did a review of the use of oscillococcinum in adults, and it showed that there was significant effect in reducing the duration of the illness of influenza by a quarter of a day. So statistically, you could say, well, that's significant. Clinically, does it really make a difference? It's arguable. But it's interesting nonetheless. And it is fueling some science further in homeopathy. So my favorite discussion really has to do with common sense, with colds, with kids. Good hand washing and hygiene, nutrition, exercise, sleep, consistent sleep patterns, and family traditions. What do you usually do? If it's chicken soup, if it's mushroom soup, one of Dr. Miller's favorites, I don't know if she mentioned her mushroom soup recipe, or if you like echinacea, if you like andrographis, if you like astragalus, if you like some of these remedies, then many of them can be used safely in kids. Vitamin D, probably one of the hottest topics in the press for the last couple of years. And it just got a whole lot more press the last 2 days, if any of you have followed the news about the Institute of Medicine report on vitamin D. So a couple brief ideas about this. There are very clear data that are documenting low levels of vitamin D in kids, in a wide percentage of the population in kids. If you look at levels that are below 30 nanograms per milliliter. There's debate about what the cutoff of normal is, and I'll get to that in a little bit. But basically, it's pretty clear consensus that there's a large population of kids that have low levels. And I see this. When I test levels in kids, they're low consistently. They are not so low most of the time to be associated with rickets, the bone disease, but they are low nonetheless. We have many, many studies that have associations between low levels of vitamin D and a wide range of chronic problems, mostly in adults, some in kids. There are data that show associations between higher or more normal levels of vitamin D and reducing the risk of autoimmune disorders like type 1 diabetes, reducing the risk of rheumatoid arthritis, multiple sclerosis, promoting innate immunity to prevent viral infections and bacterial infections, reducing the risk of depression, reducing the risk of poor outcomes from a range of cancers, and reducing all-cause mortality even. We have some associative data in kids about reduced severity of asthma, and the kids with higher levels of vitamin D in their system have found to need lower controller medications for their asthma. But all of these studies are what we call epidemiological or associative. They are not causative. We cannot draw a conclusion that by giving vitamin D it improves those circumstances. The amount of data in the adult literature that look at prospective studies or that give trials of giving vitamin D to get you to a certain level to see what the health benefits are very limited. In pediatrics, there's one. This is a study, a randomized study. It was very nicely done in Japan, looking at the prevention of influenza A during a flu season. And they gave kids, I can't remember the ages, it was, I think, school-age kids, 1,200 units of vitamin D. The current recommendation as of a week or so ago for all kids was about 400 units a day. They gave them 1,200 units a day through the winter season, and they found that influenza A occurred in only 11% of the kids who got the supplement, and nearly twice that in the kids who didn't. They also found that those kids who were not on any other forms of vitamin D and got the supplement did even better. And as a secondary outcome, they found that asthma attacks were reduced in the ones who had the vitamin D supplement. So this is a single study, and it's not enough to draw absolutely conclusive formulations or guidelines on what to do with vitamin D. But it's suggestive that there are real health benefits that are beyond bone health. Our problems is we don't know what's normal. What are the normal levels? What's ideal in kids? And the ideas for this have really gone rampant in terms of what levels ought to be normal, what you should do in people with chronic disease, and what you should do with kids who are just generally healthy. We don't know the answers yet. The levels of normal have been based on studies from decades ago that looked at what prevents rickets. So vitamin D is very active and important in bone health. We know that very, very well. We know how much vitamin D you need in your system to prevent rickets. But what we don't know and what we didn't realize is that there are vitamin D receptors throughout our entire body, in all of our organs. It's effective in our immune system, but we don't really understand the ways it's effective, and we don't really know what adequate levels are. And now that we live in a society that is essentially paranoid of the sun, we wear sunscreen all the time, we wear hats, we wear long sleeves, a sample of our population is not going to give us what would be normal to our population 100 or 200 years ago. So it's very difficult to try and figure out what's normal, which leaves us in a bit of a bind about what to recommend for kids. So prior to 2 days ago, the American Academy of Pediatrics had said 400 international units daily beginning shortly after birth throughout childhood. The Institute of Medicine report did just come out, got a lot of press, mostly because they criticized the trend to increasingly higher amounts of vitamin D supplementation. They said that the data are not there, and they focused on what we know about bone health. And I agree with that general comment as I was talking about, that we actually don't have a lot of data. Our data are associative, they're not prospective data. But they were quite conservative in their recommendations, and that's what caught the press's eye. But if you look at what their recommendations actually are, they suggest now that the vitamin D as a standard daily recommendation ought to be 600 units for kids 1 year and above. And instead of a maximum dose of 1,000, their maximum dose is 4,000 international units for kids that's tolerable. So they've actually loosened these recommendations quite a bit. These interim considerations were my personal view about what I thought ought to be reasonable for kids, 400 units the first month and 1,000 units from a year on. I still stick with that. I still think that 1,000 units is an adequate amount for kids, particularly if you're conscious about sun. It's actually very, very difficult to try and have an idea of what's a reasonable amount of sun exposure to give you enough vitamin D. There's such a wide range of things that influence it. Cloud cover, your latitude on the earth, the season of the year, the pollution in the air, your skin tone, how much time you're outside, how much skin is exposed. And it's almost impossible to try and figure that out for any individual. Okay, omega-3 fatty acids. Is everybody familiar with what omega-3 fatty acids are? The fatty acids that come predominantly from fish. So there's actually quite a bit of data about the efficacy and the benefits of omega-3 fatty acids and the balance of omega-3 fatty acids in our system. We know that omega-3 fatty acids can be used successively to treat depression. We know that they can be used, when used in high levels in a couple of studies, can be beneficial for kids with attention-related problems. The outcomes about neurodevelopmental outcomes in kids are a little bit debated, mostly because a couple of studies that just came out, but those were again using pretty low doses of DHA as a supplement. We know that omega-3 fatty acids can influence how our immune system works. A longitudinal study of looking at kids at risk for type 1 diabetes found that those had the higher intake of omega-3 fatty acids, had the lowest levels of the islet cell antibodies, or the antibodies that are associated with diabetes. There are more data expected from that trial looking at ultimate outcomes from frank diabetes itself and not just the antibodies. Interestingly, there are studies that suggest that we don't know what it might work for. It's not a panacea. Inflammatory bowel disease, or IBD here, using a large dose of omega-3s didn't help reduce or improve remission in kids who had Crohn's disease. So where does that leave me in terms of recommendations for general health for kids and families? I come back to that same beginning about nutrition. Getting the things in our diet and the things that we want to help support our system from our diets more and less from the bottle, less from the supplement, I think is probably the best way to support our health. So increasing the sources of omega-3 fatty acids in our diet from natural fish sources, from flax seed oils is a reasonable alternative, other nuts and seeds, and then grass-fed meats. If you're going to use a supplement, product selection can be difficult. If we have time to talk about this more broadly, we will. If you're interested in looking at a good reference that is not too expensive to get access to, consumerlab.com is a fantastic resource for basic background information about a wide range of supplements. And then what they do, and they're the only company that does this, is they do quality testing on the products that are out there. Our regulatory environment is such that we have a very difficult time trusting what is in the store shelves. We just don't know what's in the bottles most of the time. So this is one resource to go to look for testing, product quality testing. So cod liver oil, as another source of omega-3 fatty acids, is very attractive because it's a natural source of vitamin D as well as vitamin A. But one of the problems is that the amounts of each of them are widely variable. And in fact, if you use natural sources of cod liver oil, the amount of vitamin D and vitamin A are different from season to season, depending on when the fish are harvested. So it's hard to get a consistent quantity and know how much you're actually giving for a child. Many of them actually, in the process of producing them, there's a distillation process. It removes a lot of the odor from fish oils, and in that process they take out the vitamin D and then they add it back, and they'll add it back at various levels. So if you're going to use a cod liver oil, you just need to be very careful about reading the label so you know how much of the vitamin D or vitamin A that you're getting for kids. Probiotics. Just out of curiosity, how many of you have used probiotics at some point? Okay. So the World Health Organization defines probiotics as live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. And this busy slide is about kind of thinking about criteria for use in humans, but we're not going to get into the details. Basically speaking, they are the microorganisms that live naturally in our intestines, in our colon. And the ones that are considered probiotics by definition, when you take them, have some sort of health benefit. They have to get past the acid in your stomach. They have to survive that. They have to create some, at least, temporary colonization in the gut in order to fall into that category. There's been quite a bit of research in pediatrics and probiotics now, and it's really exploded over the last 5 to 10 years. When I first started using these, we didn't have much data about their use. And now there's much more, and there's a wide range of health benefits that they may have. If we look at antibiotic-associated diarrhea, which is when you take antibiotics and you get the runs. Well, that happens because the antibiotics kill off a lot of the natural bacteria in your gut that are important for your digestive process. So it turns out that if you give kids who have problems with antibiotic-associated diarrhea, if you give them probiotics during that same course, you can prevent a lot of that side effect. There are mixed data about the use of probiotics during, for example, a winter season in daycare centers or in schools. Some studies suggest that if you use probiotics, some particular strains during that season, you can have fewer febrile episodes, fewer diarrheal problems, shorter duration of diarrheal episodes, but some studies suggest that may not be the case, so it's a little unclear. One of the most cited studies recently was one that showed pretty dramatic effects of using probiotics in kids during a winter season, and this is very recent. In this population of kids, and this is an article published in our flagship journal, Pediatrics, reduced fever incidence by 3/4, reduced cough by more than half, and reduced colds by more than half, decreased the duration, reduced need for antibiotics, reduced school absence. Now, this is a study that hasn't been repeated yet, and it was conducted in a population in China. The quality of the study, at least how it was done, seems quite good, but you could argue that the population that it was conducted in isn't necessarily translatable to how our population's here. So we just don't know the answer yet. It hasn't been repeated well here. That said, we still have data for other uses for probiotics. This is, again, a comprehensive review that was this slide is about 2 weeks old, so this was released a little bit earlier, but a comprehensive review that shows that giving probiotics to kids who have an uncomplicated diarrheal illness, and they just have some diarrhea and a little bit of vomiting, but they're not too dehydrated, they're not too systemically ill, giving probiotics can significantly reduce the course of their illness, reduce the amount of diarrhea that they have. We know also from some very well done studies that if you give probiotics to infants for the first 6 months of their life, if one of their parents has a history of eczema or asthma, you can reduce the incidence of eczema in these kids in half by the time they're age 2, just by giving probiotics for the first 6 months of life. And it doesn't matter if you're breastfed or formula fed. That same population of kids were followed up when they were age 4 to see if this trend persisted, and it did. At age 4, you still had a reduction in about half of the incidence of eczema. There's a study going on now here at UCSF with in our Division General Pediatrics. Dr. Cabana is still recruiting for his trial of infant probiotic supplementation to prevent asthma. It's the same design. We're looking to see whether or not using probiotics can help prevent the asthma in kids. Like all natural health products, when you're thinking about probiotics, we're left in the same dilemma. We do not have, the FDA does not regulate these supplements, at least not extensively like they do for pharmaceuticals, so it's kind of difficult to pick what you're going to use. Which organism, which product, what dose, how long. Side effects are minimal in use in kids. There's a very small risk of a little bit of bloating, so they're very, very safe to use. The only exception to that is if you're working with kids who have really severe immunodeficiencies, like cancer, or they're on major medical treatments. In those cases, you always want to talk with your doctor first. But again, consumerlab.com, and I'm going to show you another reference where you can get a lot of information about some of these supplements that could be really practical for you. But the bottom line, daily health in otherwise healthy kids, a simple daily dose of getting probiotics from yogurt, from kefir, from other drinks and dairy products that have, or if you're dairy allergic, using a goat source of kefir or probiotic drink is a great source of just getting these healthy bacteria in your diet every day. Basically, when it comes to thinking about supplements and natural health products for kids, there's really very little that I think about recommending every day for all kids. Vitamin D is an exception. Probiotics through our diet is an exception. And then omega-3 fatty acids, but generally through our diet is an exception. So the only thing that I actually routinely recommend for supplements for kids is vitamin D. The other part is really about nutrition guidance. You can get most of everything you need from that standpoint. Now, in many cases, it doesn't work out that well, and we can use supplements in some circumstances, and they can be beneficial, but for the most part, it has to do with our diet. It's incumbent upon all of us, whether we're providers or you're using supplements of any kind, to report side effects. We're not going to know about how to use these products unless all of us actually take action by saying, I had a pretty severe reaction, or my kid had a severe reaction. This is available. You can talk to your doctor about it, but the U.S. Food and Drug Administration keeps records about these reactions. We need to know about it. Here's a resource for you for natural health products. If you were to go online, I don't know if you can see on your handout the web page at the bottom, but this is from the Wake Forest University Medical Center, Dr. Kathy Kemper's Center for Integrative Medicine. She has a fantastic list of handouts about a wide range of supplements for use in adults and kids. It's a great resource. And if you just Googled Kathy Kemper and Wake Forest and integrative medicine, you'd be able to find it and navigate through the site. So this is just a list of a range of mind-body approaches that can be used with kids. Guided imagery, biofeedback, progressive muscle relaxation, mindfulness meditation practices even with kids. Cognitive behavioral therapy sort of fits in this area, self-hypnosis, which we're going to talk about in some more detail, and some others. There's also quite a wide range of medical conditions that are amenable to these mind-body skills training. Whether it is autoimmune conditions like asthma or even just itching, pruritus, to anxiety, sleep problems, habit-related problems. Bedwetting is one of my favorite uses of mind-body techniques with kids. Tics, simple tics or Tourette syndromes, and then pain problems, migraines, recurrent abdominal pain, irritable bowel syndrome, all of which can be approached with some forms of mind-body skills, although this is often what it feels like. It's like, quick, fix this. Doesn't always work that way. So, well, what are self-regulation skills? What does that term actually mean? These are techniques that facilitate a person's own abilities to direct their behavior, modulate physiologic changes in desired directions, and somewhat control their thoughts for the purpose of symptom control, of attaining or maintaining health and wellness, and improving functioning or enhancing performance. Other ways of thinking about this are that self-regulation skills are emotional, mental, and physiologic skills and strategies that we use to balance our internal autonomic state, the balance between our parasympathetic, our relaxation state, or our sympathetic or excitatory state. They give kids a means to help themselves with common biobehavioral problems, and they're aimed at facilitating a child's natural and developmental drive for mastery and autonomy. From a more technical term about locus of control, which has to do with the sense of where the control of change is happening. These turn what we do in medicine on our heads. Pharmacologic treatments, some behavioral interventions, some environmental manipulation, some treatments like manual treatments, whether it's acupuncture or chiropractic or surgery or physical therapy. These are all external treatments that are done to somebody or to a child. And it's easy to subconsciously think of them as something that's done to me to heal me. But there's not as much necessarily an active role of the individual. And if instead by learning mind-body skills, you shift the locus of control to one where the self-regulation skills, the children learn an internal sense of control, the fact that they can alter their own sense of their wellness and their well-being. One example is biofeedback. Biofeedback is the use of electronic or electromagnetic equipment to measure and then feed back information about physiologic processes that can then be voluntarily modulated in a therapeutic direction. There are quite a bit of data to support the use of biofeedback. Most of it's in adults, but there are also data in kids, particularly around migraine, some about asthma, irritable bowel syndrome, Raynaud's phenomenon, which is a vascular phenomenon in the hands. Chemotherapy-induced nausea and vomiting can be adjusted by using biofeedback, and stress-related conditions. So this is a little idea of what happens in biofeedback. There's a range of sensors that can be used on muscles in the forehead, muscles in the shoulders, monitoring heart rate or sweat conductivity, and all of that data come in. You can also have bands around your belly measuring your breathing, your rate of breathing, and how much you're breathing. They all go to a computer, and this is just one image of what it might look like. But the computer screens with kids can have games. They can have big screens of color. They can have fields that fill in with color. All of that data are taken from these inputs and put on a screen that they then see. So they can see the tightness of the muscle. They can hear it in sounds that go up or go down. That information is then fed back. The computer processes this information. You get to see it on the screen. You attend to it. You learn a skill like progressive muscle relaxation, deep breathing skills, guided imagery, or hypnosis, and you realize that you can change these things and you can see it on a computer screen. And kids love the computer screen. So all it is basically another way of looking at your own brain. And for many, many kids, learning relaxation skills is kind of like, come on, give me a break. Relaxation skills, I don't need that. But when they learn to see what happens in their body in a graphic way, particularly with the computer and games, it becomes something different. And then they get to feel it, and they feel the difference that way. Clinical hypnosis. This is a skill that I've spent the last 10 years learning and working with kids. Clinical hypnosis is analogous to interactive guided imagery. And we're going to talk a little bit about misconceptions of what hypnosis is in a minute. But this definition really captures it nicely. Hypnosis is a state of awareness, often but not always associated with relaxation, particularly with kids, during which the participant can give him or herself suggestions for desired changes to which he or she is more likely to respond than when in a usual state of awareness. Spontaneous self-hypnosis can happen when you're reading, when you're listening to music, watching television, jogging, playing musical instruments, or doing whatever activity you're doing. It can happen spontaneously where you find yourself in trance. And that actually happens with kids all the time. If you watch them, they are in and out of state of trance constantly. Kids generally are far more accessible to states of trance and suggestion than are adults. We as adults frequently have a little bit more difficulty letting down our guard, letting down our barriers to allow the possibility of that engagement in trance. There's a lot of research that's done on hypnotizability in adults, but we find that we don't really actually need to do that in kids. So for adults who go to seek this therapy, frequently they'll do a series of screens to see whether or not this is something that can work for you. But for kids, we don't usually need to do that. So some misconceptions. In clinical hypnosis, one of the first things to think about is that all hypnosis is self-hypnosis. This is about teaching somebody to do something for themselves. It's not somebody doing something to them. The patient is never under the control of somebody who's a hypnotherapist. And we like to use that word rather than hypnotist. It's artificial separation. But hypnotist tends to be the ones that are entertainers. These are the ones that will have people on stage, and through their own charisma, their own suggestion, they get entertainment and they get paid for that entertainment. And this has nothing to do with that. Very different practice. And as you learn it, we learn that you never do this for fun. This is not something you do to show off with people. This is something that's used in a therapeutic context only. The child is never asleep. And in fact, younger kids, they may be walking around the room when you're actually taking advantage of trance and using the language that you're using. It's a myth, particularly with kids, that only a few people can be hypnotized. It does not mask symptoms. Kids are not that malleable. You cannot get them to pretend that they don't have something. All of one's psychiatric and normal defenses are active and available. It's not like you're trying to circumvent these in this practice. And it's more like the hypnotherapist, the therapist is a coach. And actually the language we use is quite non-directive. We talked a little bit about this. Kids are usually a lot easier to deal with in this context. So how about some of the data? This is one of the early studies by some of the leaders in the field and using the clinical hypnosis. They took a set of kids who were about 6 to 12 years old, which happens to be probably the easiest age to work with for this. And they did 2 sessions 2 weeks apart. First was just basic information about the body's immune system. How does it work? There are substances in our body that fight infections, a little bit of background information, and everybody got that. The second session, they broke into 3 groups. And one of the groups was a control group. There was a conversation, discussion with the people. And then there's 2 other intervention groups. One of them, they got a standard taped version of instructions during some set of relaxation skill. They got a set of instruction that for one group was either to non-specifically increase some immune system substances in their body. And this group B got very specific instruction to increase salivary immunoglobulin in their system. And they measured about a half hour later the levels of salivary IgA or immunoglobulin in their bodies. And the group that got the very specific discussion had a much significantly higher amount of IgA in their saliva than the other 2 groups did. So that doesn't necessarily translate into specific outcomes. It's like, well, that's nice. You know, it looks like it might actually increase, but what does that mean? More recently, some colleagues of mine who I've done some training with too, did a beautiful study in Holland looking at kids with recurrent abdominal pain and irritable bowel syndrome. And they had some specific therapists doing self-hypnosis techniques with kids, and they had a control group also that had education, the same background, specific education about IBS, some simple relaxation skills, but not the specific self-hypnosis techniques. They did these over a period of about 12 weeks, and they followed the symptoms of pain intensity and pain frequency. And in the kids who got the self-hypnosis techniques, their drop-off in pain intensity and pain frequency was quite dramatic compared to the controls. You can notice that in most studies you get placebo effects just from the context, so those got better, which you'd expect to see. But this was a dramatic effect, and not only that, it continued. 6 months and 12 months follow-up beyond the intervention of the study, they continued. This group is looking at these set of kids also, and they're going to investigate their effects a year or 2 years later, and they're looking to repeat this study in other groups of kids. This is a series of slides that we use when talking about the language and its use when you're learning about self-hypnotic techniques with kids. And it's a couple particular important points that I think may be helpful in thinking about the background of what we're doing. You know, setting expectations in kids, talking to them about, for example, well, what's going to be different when you no longer have this abdominal pain, for example. It's not necessarily a question they're going to get from most clinicians when you come in. And it's setting an expectation that, by the way, this pain's going to go away. I don't know when, but it'll go away. Validating. Did you know that lots of other kids have the same problem? That's particularly valuable in kids who are having bedwetting, because they sure as hell don't talk to their other kids, their friends about it. Demystifying. Well, what's the worst thing about having this symptom or condition? Bringing them to some normalization. What do you worry about the most? Helping to elicit the fears that they have, whether they're realistic or unrealistic. Giving information and establishing mind-body connections. Did you know that this condition can be caused by X, or that stress can make it worse? And explaining about how that works and how that happens. Discussions with kids about pain and chronic pain in this rate, and about how how our central nervous system works and why it is that we experience pain the way that we do. Shifting again from an external to an internal locus of control. Won't it be great when you learn ways to help be the boss of your own body? Or if you're working with teens, language that's more developmentally appropriate. And then reframing this issue, and particularly kids who are dealing with chronic conditions. Is there anything good that you've learned about yourself from this problem? Can you think of all the things that you do despite having this symptom or problem? So these are all just general considerations. So one of the keys about using mind-body approaches with kids in general is that kids should be motivated to change the problem. This is a really important point when thinking about mind-body skills in general. If I have an 8-year-old who comes into my office whose parents say, he wets the bed, make him stop. Whose problem is it? So yeah, you gotta figure out whose agenda are you working with, and help both the parents and the child understand what's happening and get to a point where they can work on thinking about addressing the problem a little bit differently. Language choice is key. How about at home? What about mind-body skills and stress management at home? One of my favorite questions for parents is, well, how do you model stress management at home for your kids? If you're concerned about the stress level, the difficulties your child is having with schoolwork, with bullying at school, with the other aspects of difficulty in their life, what they can or can't do, how do you show them about how you deal with your own stress? Not tell them, but show them. The same question about the nutrition. You can say all you want, but it's what you do that speaks the loudest. The things that you do every day, probably, that we don't even realize that really have to do with reframing issues from a mind-body standpoint. Kids fall, they get cuts, they get bruises, or they just kind of stumble. And have you ever seen a toddler who stumbles and falls and just kind of looks up expectantly at a parent as if, I don't know if I'm going to cry, I don't know if I'm going to scream, I don't know if I'm okay. And the next statement or the reaction from the parent, especially if it's done over and over and over again, you know, in individual time, it doesn't really matter. But our pattern of how we react to kids when they're stressed can help them engender their own internal sense of relaxation or dealing with stress. So one response might be to show an expression of worry, come down and say, oh my God, are you okay? Which in some cases is totally appropriate. But if you do it every time, it sends a message that I should be worried about what just happened to me. And then if on the other hand, what we do is say, oh, come on, get on up, you're good, you can keep going. And you know it inside, it sends a different message to the child. You can use reframing techniques or thinking about, talking about nightmares with kids. There's actually some data, and there's a group of people in Texas who teach adults mind-body skills to change their nightmares. And they actually rehearse, they actually learn how to rehearse and shift their own imagery in a waking state that alters to some degree what happens in their nightmares. And the way you can do this with kids is you can just talk and hear about what their nightmares are, what their worries are, and you can wonder with them, I wonder how you're going to solve that next time. What's going to happen when that particular monster comes up? Have you ever tried talking to them before? Did you know that most bullies, most of those really meanest guys in the world, man, they're just full of it, and they're just trying to scare you. And if you actually went up to them and said, hey, why are you so mean? You might actually get a response. Could be interesting. I don't know. You know, you might be wrong, and they might come back to you the next day and say, that didn't work. But you might be right. And it's just offering those kinds of hints and suggestions, reframing what's happening in their scary moments, and thinking about, and also offering them an opportunity. How are you going to solve it? I don't know what the best way is for you. These kinds of ways of thinking about these issues with kids can be really helpful for them. Physical contact is huge. Big part of what's really important for kids dealing with stress every day. I like this quote. It comes from a book called The Nature of Suffering and the Goals of Medicine. Healing consists only in allowing, causing, or bringing to bear those things or forces for getting better, whatever they may be, that already exist in the patient. And this from Rachel Remen, who's one of my favorite teachers. In protecting people from disappointment by not giving them false hope, what we end up often doing is giving them false despair. Okay. Science and art, a little bit about the environment with kids. Briefly about pesticides, a little bit about organic diets, and then a little bit about green space and what that is. We have a growing amount of data that suggests particularly organophosphate exposure, pesticides, neurologically based pesticides that are used in agriculture can have effects on kids' development. There are a range of studies, some of these conducted in the New York City area, some conducted in other areas, that suggest if you look at organophosphate levels measured as biomarkers of metabolites of these products, either prenatally or afterwards in maternals. Most of these are actually measurements mostly in women during pregnancy and looking at neurodevelopmental outcomes in kids later. We found that in some measures, kids have poorer performance of mental development. They tend to be subtle, but they tend to be real and significant in a number of studies in kids. More recently, and just published this year, and here in Salinas Valley, looking at the Mexican-American population of kids living in an agricultural area in the Salinas Valley, looked at, again, the specific metabolite of organophosphate exposure measured during pregnancy and looking at neurodevelopmental outcomes in kids at age 3.5 and age 5. And these were specifically measures of attention. Higher levels of organophosphate metabolites were adversely associated with attention as assessed both by maternal report, by specific psychometrician observation, and direct assessment. And in fact, it was more robust when kids were 5 years old than it was when they were 3.5. There appears to be really significant associations between organophosphates. Now, to really be certain, these studies probably need to be repeated again, but it looks real. So one might ask then, well, does organic matter? You know, if you do have organic diets, is that significant to make a difference in this? Well, this is a study that was published just a few years ago looking at kids as a randomized, what we call a crossover trial, where this is actually a small group of kids, but they substituted conventional diets with organic diets for 5 days. So you had a washout period where everybody was on the same diet for a while, and then you kept kids on a conventional diet, put others in 5 days. They collected urine samples throughout a 15-day period throughout the whole study. So they were on, one group of kids is on the conventional diet, another's on an organic diet, and they switch after 5 and have a washout, and then they switch again. They found that the urinary concentrations of metabolites for a number of these pesticide exposures decreased to the non-detect levels immediately after going onto organic diets, and they stayed that way throughout the period they were on organic diets. And as soon as they went back to conventional diets, it came back in their urine. So we know that if you do eat organic, you have less of these metabolites in your system, but this study did not look at outcomes. It didn't say, are there behavior changes? Are there neurodevelopmental differences in these kids? What happens if you wash it out for a longer period of time? We don't know the answer to that. So it's actually not possible for me to say, based on this study or the other studies, to say, you really need to eat organic, otherwise it's really going to severely negatively affect you. I think from a precautionary principle standpoint, if we think about trying to avoid harm, it's very reasonable to try and eat organic produce as much as possible. Use resources from the Environmental Working Group that talk about what are the most heavily contaminated fruits and produce. If you go online and find this information, you can find the foods that are non-organic that are actually reasonable to eat if you want to try and reduce these exposures. Cost is definitely a factor. And it's not every family that I recommend this to because we don't have enough evidence. But so, for example, if you're dealing with a kid who has pretty severe behavior issues or attention difficulties, being on an organic diet is a reasonable component to a broad range, a holistic approach to thinking about ways that might help. How about physical activity and where we get our physical activity? We're all very familiar with, at least we're not going to go over the data about physical activity and health benefits on obesity, cardiovascular health, chronic pain, psychological health, many, many others that we know about regular physical activity that helps us in general health. Data about where you get that exercise, whether it's in a gym, on a treadmill, on a street in the city, in a park in the city, in a national park someplace else, the amount of green space, we don't really know. But it turns out that there's some early evidence that suggests where you get this physical activity and exercise actually can make a difference. And some of that data is in kids. This is a really interesting study that was done in Canada that took this idea about where kids play and how it influences their social dynamics amongst themselves, their creativity in play, and what happens. So they took 59 schools in Canada that predominantly had asphalt-based playgrounds. And they randomized them, and in some of them they built green space. So it was a built environment, but it had a lot of environmentally green spaces, but also with play structures and places where kids could play. And they looked at these kids and they looked at behavior patterns and changes of them over time. What they found was a big change in what appealed to kids, what promoted more active play, that they found that the percentage of the respondents agreeing with these positive promotions of changes in more constructive play, more civil behavior among students, more active play, more exploration of the natural world. All of these things were significantly improved in the playgrounds where they had more green space. But interestingly, to me, one of the most fascinating parts of this study was that what they found was the social dynamics changed. In schools that had predominantly asphalt-based playgrounds, the kids who were the biggest and the strongest, the most athletic, were the leaders. They were the ones who really kind of took the social leadership of the group. And the ones who had the more green space, the more places where there were more places to be creative and different in the environment, they found that the kids who were more academically achieved, the kids who were more creative in their ideas, became the leaders of the group. Now, what's important to me is not to say that one is better than the other. But if you only have one of them, you're leaving out a significant portion of other kids. You need places where kids can thrive in the environments where there's enough diversity for them to take advantage of what their natural skills are. So how about the use of green space, particularly for some health conditions? This is a group of researchers that have looked at this question, and they have wondered whether providing outdoor exercise or exposure to green space makes a significant difference for kids. This is a study that looked at a 20-minute walking exercise in school-age kids, and they measured measures of attention after that period of walk. And this was again like this crossover study. They took the same group of kids, and one time they did a walk in a very urban setting. One time they did a walk that had a little bit of green space, and one time they did a walk that was in a wide variety of green space, mostly green, but all in a city. And each kid did each one. And they measured their attention capacities after a 20-minute walk that was led by an adult. And they found a significant difference in these kids that when conducted in green spaces, the same activities reduced the attention problems in the kids more significantly. It's a single study again, but it's a really interesting idea that just the exposure to nature can make a more significant difference than just being outside. Oh, a little bit about greening and green environments. There are a lot of resources that can help find ways of reducing environmental exposures and toxins in your environment. Deirdre Imus has a program in New Jersey looking at environmental health related to a cancer center. And this is a book by Susan Marriott also about Green Baby that gives you some tips about how to reduce environmental problems. But I ended up coming to this conundrum. And I really like this slide. I don't know if you guys can read this. But the first setup here says, organic apples, $2.99 a pound, organically grown in Australia, then transported here by burning fossil fuels that cause global warming. Option 2, conventional apples, $1.50 a pound, grown in the US using illegal workers and dangerous pesticides that pollute local groundwater supplies. Or option 3, bargain bin apples, 79 cents a pound, grown in South America using slave labor, contaminated soils, and neurotoxic pesticides banned in the USA. It is so hard to try and pick what really works. So you just do the best you can with the resources you've got. And ultimately, don't worry about it, because what effects are going to be there are probably going to be mild. If you're dealing with pretty significant conditions, then maybe you can think about being more strict about it. But overall, do the best you can, but also know that you vote with your dollars. And what you encourage in production by purchasing will lead to what we deal with later, what options we have later. I think I'm going to wrap up there. This was just a brief discussion about alternative systems and other components. Ask your physician, talk to your doctor about a range of complementary modalities. If you push them, this whole movement of integrative medicine came from people like yourselves who said, I need to know more. I want to know if it's safe to do this. I want to know if it's okay to use chiropractic in my kid. And believe me, the pediatric community is going like this, oh my God, what do I do? You know, but if you keep pushing, we're going to get better and better information. There are sections within our professional societies that deal specifically with this now. And this is what I hope to show more of my colleagues eventually over time. So with that, I think we'll wrap up with that. Thanks very much for your attention. I know that was a long haul, but I appreciate it. Basically, the gist, if I get this right, had to do with a concern about the shift in development of maturity, particularly in young girls. The younger and younger ages at which young girls are beginning to develop signs of puberty. In the context of our growing understanding about neurodevelopmental changes and the fact that it takes quite a bit of time for our frontal lobes to develop appropriately for decision-making capacity, for aspects of how we're able to maintain focus and attention. And then you also brought up a question about association of early menarche and possible associations with increase in violence in young girls. And wow. You know, you are absolutely touching on the issues that drive many of us into thinking about the healthcare issues more broadly. You know, that motivate us to say, these are serious problems that we don't know the answers to, and there are changes in our environment that we're afraid are significantly contributing to this issue. It's happening so fast, it's not a genetic, environmental, or genetic, what's the word I'm looking for? Evolutionary change. This is more of the things that falls into the area that may be what we call epigenetic change, where you have environmental changes, whether there are changes in the toxicology of our environment, the chemicals in our environment, the changes of our nutrition that affect how our genes are expressed in a much more rapid rate than they are about actual natural mutations of our genes. So we don't know the answer to that problem, but it's definitely a problem. And it's they're roughly the same age you were saying, is that you know, menarche is happening at around 12, 13 instead of 15 or 16 as it was decades ago, and we don't know why.